they're always communicating with you, even if they're not physically speaking to you. But that's what's kind of the nerdy cool part about being a CRNA, is because you get to use your critical care knowledge and skills to assess what is going on, to inference what they're telling you, what their body is telling you. So that is a responsibility of a CRNA, that your patients will be asleep under anesthesia and you have to understand what they need despite them not being able to physically tell you what they need. So again, your responsibility is to keep the patient safe, keep them hemodynamically stable, and to keep them free of pain as much as possible, right? So the beauty of being an anesthesia provider is your main goal is to make sure they wake up, they are hemodynamically stable, that they obviously go to sleep smooth, wake up smooth. I'm Jenny Finnell, CRNA and founder of CRNA School Prep Academy. I have always had a passion for helping those who aspire to become a CRNA. A couple of years ago, I started mentoring a handful of prospective students. Fast forward to today, and I have a successful mentoring program that has impacted hundreds of aspiring and now current nurse anesthesia students. What I enjoy the most in my business is connecting with you, the future CRNA. I love learning and growing with you. The road to CRNA is full of unique challenges, and no two journeys are the same. But every journey has a learning opportunity. I'm here to share what I have learned over the years from not just my students, but CRNA community leaders, program faculty, and from my time as a practicing CRNA. This will be your one-stop shop to get the mentoring you need to not only guide you into this career path, but support you all the way through to graduation day. So if you're a nursing student who's exploring the possibility, an ICU nurse actively pursuing CRNA, or a current nurse anesthesia student, you're in the right place. Tune in for inspiration and actionable takeaways that will help you from start to finish. Let's get started. What are the true differences between being an RN and a CRNA? In today's episode, I'm going to dive in and compare and contrast things like the education, the responsibilities, the work environment. So let's go ahead and get into today's show on what are the differences between being an RN and a CRNA. All right, so on today's show, you guys, again, we're going to talk about the differences between being an RN and a CRNA. I thought this would be a fun way to compare and contrast, because I'm often asked things like, how does the education differ between nursing school and CRNA, and what should I expect? Same thing as far as what are truly the responsibilities, how is it different than being a nurse, as far as day-to-day tasks and actually responsibilities as far as patient care. So I thought this would be kind of a fun episode to kind of just dive into all these different topics and really compare and contrast being an RN versus a CRNA. Now, I also want to start this episode off with saying that you're going to get me with my ICU nurse experience. I don't have a vast variety of nursing experience. I know a lot of you have very diverse backgrounds in nursing. You've been an OR nurse, a PACU nurse, a flight nurse, an ICU nurse, a med-surg nurse, all those things. I don't have that experience. So again, my narrow little window of being an ICU nurse prior to being a CRNA is what I'm going to speak towards. However, I encourage you, as I'm going through this lecture today, this podcast episode for you guys, that you actually stop to kind of think about what does this look like for you and your experience in nursing. And also, just for those of you who are new to the show, welcome to CRNA School Prep Academy podcast. I'm your host, Jenny Finnell, CRNA. I'm so excited to have you. If you're a repeat listener, welcome back to the show. Thank you so very much. So let's go ahead, and first we're going to discuss the education and the differences between becoming an RN and becoming a CRNA. So becoming a CRNA, I hear a lot of people say, you can't compare nursing school to CRNA, that there's no comparison, right? Now, whether that's true or not true, you can always make a comparison. I mean, I would like to argue the fact that you can always make a comparison. So if I had to make a comparison, there's a couple of things I want to point out first before I actually make this comparison. And number one is the fact that at least for me, when I was back in nursing school, I was much younger, and I was also still very much so figuring out what works for me as far as my study techniques, how I learn. And also, let's just be honest, back then when I was 19, 20 years old, I cared a lot about my social life, where when I went to grad school, I did, but not nearly as much as I did back then. So let's just be upfront with the fact that when you're a young learner, you are just different as far as your maturity level and your ability to handle pressure, and it could affect how successful of a student you are, right? So that being said, when I was a younger learner, I would crack a little easier and I would flounder a little bit more, and I was struggling more because I didn't know what worked for me, right? It took me some time in college to really figure out, okay, I need to address the fact that I'm not getting the grades I need to get into nursing school. Why is this? What can I do differently? How can I adapt? How can I improvise? And if you have been a follower of this podcast for some time, you've probably heard my story in the sense that I didn't start off being a straight A student. In fact, I never had been a straight A student. I was the student growing up who just struggled, and I didn't really know why. I thought I was stupid, et cetera, et cetera. It turns later on even in high school, I found out that I had dyslexia. Now, I would say that my dyslexia is mild. In fact, unfortunately, not unfortunately, because I think it's a strength. I'm not saying that, but I know I'm going to watch my son struggle because I'm seeing it. My son, who is started kindergarten last year, is going into first grade. So I'm seeing a lot of similarities in my son. And so we're getting help for him early on. But that being said, I didn't identify this issue until I was much older in my education career. And I just assumed I was dumb, right? And so when I was in college and struggling in my pre-nursing curriculum, right, I just actually had the thought was, maybe I'm not cut out for this. Maybe I'm not smart enough to become a nurse. Like, I legit thought that. It wasn't until I was kind of pushed up against a wall and to make a decision of whether going back home to live with my parents and going to a community college, or trying to figure out how to get good grades so I could stay where I was, which was at Ohio State, and get accepted into the College of Nursing. I made a go. I mean, I was like, okay, it's now or never, and I got to figure this out. And I tried every study technique on Google, and eventually I figured out what worked for me. It was very intense. I spent an entire summer doing a full load of relatively easier courses, right? But I took that time with easier courses to really figure things out for myself. So as a young learner, I figured out early on in that point in my life how to learn effectively. Because I did that, because I did this one thing, it did make grad school way easier. And I see students all the time who tell me that there's no comparison between nursing school and CRNA school, say because it's so much harder. But the reality is, you guys, like, don't get me wrong, I thought studying in CRNA school was incredibly hard, but I also knew at that point in my career, my academic career, I knew how to study effectively for myself because I made it happen for me in my undergrad. Once I took that summer load of courses after my nursing school rejection, I got straight A's for the first time in my life. And I never looked back. I actually became a straight A student for the first time in my entire life. I mean, I still get emotional thinking about it because I just didn't, there was a point in my life where I didn't think that could ever happen, right? I thought it was not possible for me. But that's also when I became a firm believer everything's possible. Everything is possible. You are capable of so much. You just have to believe in yourself, and you have to give yourself the chance. And that means the chance to fail even, okay? Because you can always adapt and learn and adjust. So that being said, thinking about how my study techniques served me in grad school was the fact that I knew what worked, and it was still hard, okay? I knew it worked, it was still hard. Those of you who maybe get through nursing school and don't figure this out, or who get by, right? I will tell you that you will be in for kind of a rude awakening when you hit your education in CRNA school. You're going to get slapped in the face. It's going to be like a gut punch, right? You're going to get the wind knocked out of you. And you guys, it's not because the information is so much harder. It's simply the fact that there's so much. It's like they take a dump truck of textbooks and knowledge and dump it right on your head. And if you can't figure out how to hold it up without crushing you, you will be crushed. And so the reason why I'm pointing this out is because it's not like a brand new thing. I mean, it's studying and now knowing how to study effectively, and not just effectively, but efficiently, right? Efficiency is really key, and time management is key. So it's not just your study techniques or how effective your study techniques are. It's the efficiency piece, and it's the time management piece that really makes a beautiful picture, right? And even if you have good time management, even if you have efficient and effective study techniques, CRNA school will still be hard. So the sooner you address this one piece in your academic career, as far as, do I have a good solid study technique? Is it efficient? Am I good at time management? Am I organized? I promise you, if you get down to the bottom of this, the sooner the better, the easier you're going to feel like CRNA school is going to be. But that being said, it's not going to be easy. But because all things that are worth it in life, let's just face it, like becoming a parent, being a parent is not easy. It is one of the most rewarding things you'll ever do. But holy shnikes, it's not easy. A lot of things in life are not easy, but they tend to be the most rewarding pieces of your life. And this is one of them, you guys. This is a piece of your life that's going to be incredibly hard, but also incredibly rewarding, which is why I'm so fortunate and honored and grateful that I get to share this with you, share your CRNA journey with you. So that's number one, is education. CRNA school, it's a lot of information coming at you very, very quickly. So that's like the biggest difference between nursing school and CRNA school, is the fact that like it's much faster pace, and when you get behind, it's going to make it so much harder to ever get caught up. And then the anxiety sets in, overwhelm, the panic attacks, the whole 9 yards, right? And I'm speaking from someone who did suffer from panic attacks in CRNA school. It wasn't just because of the academics. I had suffered panic attacks in undergrad, so this wasn't a new thing for me. Like I had dealt with panic attacks from the time I started college. And it would occasionally flare up, and what I found was my panic attack started when I would not handle stress well, not cope well, bottle it all in, and not like have a release, right? And then usually after a really stressful event where I just put myself through the ringers emotionally, I would then have a panic attack a day or two later. And typically if you look up the science behind panic attacks, which of course I do because I'm just a huge nerd and I like learning these things. Panic attacks actually happen when your sympathetic nervous system kicks back in and you relax. And then your body can go into the panic attack because again, you've kind of shut off that sympathetic surge and you've kind of started relaxing again. That's usually when you start getting the panic attacks. It's usually not when you're panicking. It's usually a day or two later. And you guys, if this is happening or if you're nervous about this happening to you, all I can say is like, find a way to just address it head on. I mean, when I have addressed things that are bothering me or that cause problems in my life head on versus saying, it'll be okay, it'll be okay. Like, don't tell yourself it'll be okay because that's meaning you're neglecting it. You're not addressing it. And I, don't get me wrong, I like reminding myself, Jenny, it'll be okay. You're going to get through this. But you also still have to face the elephant. You still have to face whatever's causing that. And until you do that, the problem's never going to go away. It'll be okay, but it's always going to be in the room, right? Versus saying, hey, elephant, I see you over there. Let's have a conversation. Let's try to get to the bottom of this so I can shrink you and not have you so impactful in my life, right? So that's a piece of advice I want to share as well, kind of off topic, but I thought I'd bring it up. But yeah, so it's the amount of volume that you're going to deal with as far as material that you're going to cover. Also, the way I picture CRNA school, at least it was for me, and I think it is for most, is you kind of have to have a good foundation because you build on that foundation. So if you find yourself rusty in things like chemistry, physics, anatomy, pathophysiology, pharmacology. Now, before you go start hitting all the YouTube videos and all the books, just stop. Let me reassure you that you are okay. You do not need to do that. But what I will say is know where your weaknesses are. Assess where you think, if any, you had some weaknesses in the past. Did you struggle in chemistry? Me. I always struggle in chemistry. But that being said, there's such a narrow amount of chemistry that you need to know for CRNA school. And I never even thought to hit. I mean, I don't even know if when I went to CRNA school, you guys, I don't think Khan Academy existed. I don't even know if I knew how YouTube worked back in, I'm totally dating myself, holy moly. But like back in 2012 is when I started CRNA school. There just wasn't nearly the amount of known resources on the internet like there are these days. But that being said, I'm kind of glad there wasn't because I didn't waste my time. And which is why we developed the NAR boot camp, the Nurse Anesthesia Resident Boot Camp. Richard Wilson, he is an assistant program director and educator for over 12 years in the CRNA program. He taught chemistry as like a pre-course. So when you start your CRNA program, you are refreshed. It's there. So if you have not utilized the NAR bootcamp inside CSPA, make sure you do that. Again, physics is in there too. Again, because the physics and chemistry you learn for CRNA school is very, very specific concepts. It's not like the Krebs cycle. I mean, I had a student reach out to me and it's like, oh, I'm struggling with the Krebs cycle. I'm like, you don't need to know the Krebs cycle for CRNA school, so don't even worry about that. So that's what I mean. Don't go binge all the Khan Academy. Just focus on what we teach you inside the NAR bootcamp, inside of CSPA, and you're going to be golden. And the same thing with like pharmacy. We do pharmacology as well for that very reason, because maybe you might feel kind of weak. Now, when it comes to anatomy pathophysiology, I highly encourage you to dive deep into our learning library. That's essentially what we teach in there. There's a lot of pathophysiology processes that relate to ICU nursing and anesthesia. But that being said, kind of identify where your weak points are and then hit those weak points and don't worry about everything else. And again, if you want to hit everything, then just do the NAR bootcamp. You're going to be golden, and maybe hit the learning library. Again, if you think your pathophysiology could use a tune-up. But yeah, so that's kind of my piece of advice too, is make sure your foundation is pretty solid, because they're going to be expecting pretty quickly to add on to that foundation. And that's what you do the entire time. And one piece, if I had to give you any pieces of study advice to kind of make your time, your education in CRNA school smoother, is don't focus on memorizing, focus on understanding and building out concepts. I was trying to explain this actually to my husband the other day. For those of you guys who get our emails, my lovely husband, Brandon, he's amazing. He writes all the emails. He's so good. And I'm really incredibly grateful and thankful for that. So I did just kind of spoiler alert that I'm grateful that that's not on my plate along with everything else that I do for CSPA. But that being said, I was trying to explain to him why, we're getting ready to have our conference, or actually by the time you see this episode, we would have just had our annual virtual conference. Dr. Terry Durbin is teaching the neuroscience behind learning, and I'm super nerding out on this because I think this is really fascinating, but I was trying to explain to him why this concept is so important for students to get early on. And if you think about it in CRNA school, if you have A, B, C concept, right? But say you're tested on the B concept, but when you learn A, B, and C ideas, you're trying to connect them, meaning how does A relate to B? How does B relate to C? How does C relate to A? How does A relate to everything? I don't know. You're just simply trying to build a roadmap of concepts that you're connecting. And the reason why this benefits you in CRNA school is because you don't have to memorize everything. In fact, you're not going to be able to. I'm just going to be honest with you. It's just too much, right? You can only have so much memory. But when you connect concepts, when you understand how they connect, you can then make good educated guesses and like reference, like, okay, if this is how C works with A, then I can reference that C works like this with B. Or if B works with A like this, then I can say that A potentially works like this with C. And these are just different concepts that you can kind of circle and connect the dots. And so when you get a test question on B, even if you don't know it, you can say, well, I know A and I know C. How do A and how does C connect to B? And kind of go in this big circle in your brain, and that allows you to make a really good guess, and a lot of times allows you to figure out the answer without even knowing like the actual question. So that's my biggest piece of advice as far as how to take test questions, how to, when you study, connect the information to other concepts that you have already learned and truly understand. And this really allows you to be a better test taker. The other thing I did too is I would not read my answers, meaning I would read the question on the test, blinders, don't look at the options, figure it out before you even look at the options. Most of the time you can always have a pretty quick answer in your brain. If you don't, that's when you start connecting and brainstorming, writing down different ideas, and then look at the answers after you've brainstormed some ideas around that concept, and then start trying to do that whole process where you're connecting the dots and pulling the information out of your brain. If you think about your brain as like kind of zipping a file and you have to unzip it and piece by piece, that's kind of what you're doing when you're doing stuff like that. Which is super cool and nerdy, and I love it. All right, so that's the education piece between the differences between nursing school and CRNA school. It's the fact that you are going to be getting a lot more thrown at you a lot quicker, and you don't have time for the basics, right? You already expected to understand the basics. All right, now responsibilities between a CRNA versus an RN. Well, I mean, this may seem obvious, but maybe not. I don't know. So I want to just point it out. Obviously, we always have a responsibility to the patient, whether you're a nurse or a CRNA. That's the beauty of being a nurse, right? That's why you went into nursing, because you enjoy that patient connection, because you enjoy being at the bedside. You enjoy doing the hands-on things. That is why you became a nurse, because you want to make a difference. You want to help people and be right there present to actually help them. So that has not changed. You still get that connection. A lot of people say, well, you don't have time to talk to your patient. Do you miss that? I'm like, I have 5 minutes in pre-op, and that is plenty of time to build an incredibly deep bond, trust. I mean, they're putting their life in your hands. The bond you build in that 5 minutes of them asking you questions and you educating them is really strong, and it's really powerful, and it's really rewarding to know that they trust you enough to put them under anesthesia while they're being cut open and then wake them up. It's I don't know how to describe it, but you don't have all case to chit chat and talk or interact with them, but you always communicate with them during the case. You listen to their heart rate, assess their vitals. Ouch, Jenny, I'm having pain. My heart rate's going up to 140. You better help me. That's them saying that to you, but they're not actually saying that to you. So technically, you always communicate, you always interact with your patient, even back in the OR under anesthesia. And even in the ICU, you guys, your patient's intubated, sedated, you are communicating with them the entire time. You know when they're starting to buck the vent, you know that they're either having pain, that they're getting light, they're getting agitated, what's going on, right? Or if your alarm's going off because their blood pressure's low, or they're telling you that they're, getting more septic, their lactic acid's increasing, whatever is going on with the patient, they're always communicating with you, even if they're not physically speaking to you. But that's what's kind of the nerdy cool part about being a CRNA, is because you get to use your critical care knowledge and skills to assess what is going on, to inference what they're telling you, what their body is telling you. So that is a responsibility of a CRNA, that your patients will be asleep under anesthesia, and you have to understand what they need despite them not being able to physically tell you what they need. So again, your responsibility is to keep the patient safe, keep them hemodynamically stable, and to keep them free of pain as much as possible, right? So the beauty of being an anesthesia provider is your main goal is to make sure they wake up, they are hemodynamically stable, that they obviously go to sleep smooth, wake up smooth, and also that they're going to recover smoothly, that they're not going to have, a lot of pain to deal with when they do wake up. Or again, maybe you're not even waking them up. Maybe you're just taking them back to the ICU, but you're making sure you drop them off as stable as possible, right? You're assessing their labs and all their fluid status and all of that stuff. So that's your responsibility, is to make sure ultimately the patient's safety is your priority. Same thing when you're a nurse. That's always your priority, is to make sure the patient is safe, that their needs are being met, right? Now, obviously, this looks different depending on what type of nurse you are. I mean, even in the OR, they may not be doing a lot of direct patient care, but they're working as a team collaboratively to make sure that the patient's needs are being met. They're communicating, they're collaborating to make sure, hey, this needs to happen so X, Y, and Z happens. So ultimately, your responsibility is still the same. It's just kind of carried out in a different manner depending on the role that you're filling, whether you're an ICU nurse, whether you're a CRNA. As an ICU nurse, I was advocating for that patient all the time because they were intubated and sedated. I had to speak up and address what I thought they needed. You're doing the same thing as a CRNA. If the patient wasn't intubated and sedated, well, then I could have a conversation with them and educate them. That was part of my role as an ICU nurse, but you're also educating your patient in pre-op, in PACU. Now, they may not remember in PACU, but then you pass on the education to the PACU nurse, okay? And so you're still technically doing all those things, you're just doing it in a different way. So that's a similarity and a difference all in one. All right, let's talk a little bit about work environment. This is probably where it probably differs the most, I would say. Maybe this is one of the areas that differs the most. So I'll go into the scope of practice is probably where it differs the most. But obviously, work environment as a CRNA can really vary from hospital to hospital, practice to practice, specialty to specialty. So the environment, you don't have to work in an operating room. Okay, you can work at a fertility clinic. You could work at an ophthalmology clinic. You could work at a dental clinic, a plastic surgeon's office, a med spa even, and do plasma facials and Botox injections, right? That's now pretty far removed from the operating room. But you can also work at a ketamine clinic, which is like a pain clinic. But you could work at a surgery center, regular level 1 trauma center, all different variety of settings You can even go into education. You can even go into being more politically involved in like the National Association, things like that. So there are a lot of different types of work environments CRNAs can work in, but I would say the probably most commonly thought of and probably the most common is in an operating room to some extent, right? Or an outpatient procedure like maybe CAT scan or MRI or IR or I'm trying to think where else I go off-site. Those are probably the primary ones. Maybe EP labs considered offsite, like doing cardioversions and things like that. So again, work environments, but typically you're working where people need sedation. Okay, that's essentially the work environment. People need sedated for one reason or another, and you're there to provide safe sedation and monitor their vitals and make sure that they are maintaining their airway, they're exchanging, they're oxygenating, and their blood pressure is in the heart rate, all of that, all their vital signs, fluid status, all that is good. Now, the challenge of this is it varies case by case. If you're doing a big bowel case, their fluid needs are going to look a lot different than someone who's coming in to have a colonoscopy, right? Same thing if you go up to OB and do a C-section, well, that's a spinal anesthetic versus what if you just place a labor epidural? You're still providing anesthesia. When you place a labor epidural, you're still assessing the patient, asking them questions, and checking on them and checking on the epidural and assessing whether it's effective, right? But it looks very different than actually putting someone under general anesthesia in an operating room and managing them like that. So again, your work environment, and in one day, you guys, I did 24-hour shifts for a while. In one day, I would maybe do like 2 open heart cases in that 24-hour period, 2 or 3 open heart cases. And then maybe I would go up to OB and do 3 or 4 epidurals. And maybe I'd come back down to the OR and do an add-on lap appy for a 6-year-old, or a cold leg. A cold leg would come in the middle of the night, So again, my shift was very different, and I could do OB, peds, hearts, all in one day. Now, try to tell me what nursing specialty that you can do such a wide variety of patient cases in one day. It just doesn't exist. You just can't. You can't go do an OB case, then jump into an open heart room, and then jump into a 6-year-old lap appy all in one shift. Like we're very privileged to be able to have the expertise to really manage a wide variety of patients. I would say like ER nursing or flight nursing maybe sees a wide range of patients, but doesn't necessarily mean you're taking care of a pregnant person and a child in one shift. But you could, I guess, technically, if they come in, need an emergency of some kind, flight somewhere, hopefully not, it'd probably be a bad day. So yeah, I just feel like our specialty is really unique in the sense that you see a wide range of patient populations. You have a wide range of knowledge because let's just face it, doing a case on a 6-year-old versus a pregnant person versus an open heart on a 65-year-old, vastly different physiology, vastly different needs, right? And so you have to understand all of that and what kind of anesthetic is safe to deliver for each one and what their needs are going to be for pain control, fluid, all of that stuff, how to dose an epidural safely, right? How to dose a spinal safely, so you're using a lot of different skills all in one day. So that's probably a big difference as far as work environment where like in the ICU, don't get me wrong, I saw a wide range of patients that have GI bleeds, septic shock, chronic renal failure, tons of respiratory failure, just a wide variety of different types of cases in the ICU, but essentially my role as an ICU nurse was relatively the same day in, day out. I did the same things every single day. I saw the same types of patients. I didn't see a giant range in age. Maybe youngest would be like in their 20s, and the oldest would be in their 90s. So that's a wide range, but we didn't do babies. We did occasionally have some sick intubated pregnant people, especially during like the H1N1 when that came out back before, anyways, so let's not talk about that. Anyways, so yeah, I think as an ICU nurse, for the most part, my shifts felt pretty routine, felt pretty predictable, like not like you knew exactly what was going to happen, but I knew what my responsibilities were every single day that I go in. Where when I go in as a CRNA, especially as a 24-hour CRNA, I don't know. It's like, what am I going to get today? What's going to come on my plate? I don't know. It could be a buffet of all different ranges of stuff. I don't even know. Like I said, it's kind of, I like that. It kept me on my toes. It keeps me mentally challenged. That's also why when I hear people say that anesthesia can be boring, I'm like, I don't know who you heard that from or why you think that, but in my opinion, you just haven't challenged yourself to see enough of what we do, because there are plenty of things that you can do as an anesthesia provider that are truly not boring. If you put yourself in a colonoscopy center and just sit there for your entire career, well, I would think that would be boring, but you're making that choice for yourself. And so if you don't like that, then don't do that. So that's what I like. The way I am with my career and my experience as a CRNA is I challenge myself. I went from doing a level 1 trauma center where I was doing open heart, OB, peds, as much as I possibly could. Then I took a job doing outpatient surgery, but I did a lot of regional blocks. I hadn't done that since school. I challenged myself to do a new skill because I hadn't really done it since school. So I went and started doing 30 blocks in an 8-hour shift, which was incredibly challenging, got me good very quickly at them. But it wasn't for me, right? I decided I didn't like the outpatient surgery center world. So I went, and then I was like, well, I've always liked peds, but I've never done just peds. What would it be like to work at an actual true peds hospital? So there I went. And I love it. I love working with kids. So I'm a peds CRNA now. Just took a 1099 position at an adult hospital. It's a small OR, maybe 10 ORs, all adults, and just kind of a general variety. So I'm going to get my taste of adults again. So it's kind of, mix it up a little bit, stay fresh. And also this rural location that will allow me to do my regional blocks again. So I'm going to refresh those skills again. So always look for ways to keep your practice fresh, keep your skills up. You will never get bored if you do that. And there are so many opportunities out there that it's easy to allow yourself that. So that's kind of the work environment as far as compared to nursing. Again, depending on the nursing environment, your environment can be very different than that. But I'm just speaking from the ICU world that I essentially was very predictable that I'd go in, I'd have 1 or 2 patients, and I essentially had kind of a routine that I practiced day in, day out. Whereas a CRNA, don't get me wrong, anesthesia can be a routine, but can look very, very different, right? I mean, to go up and to do OB, and then over to do a general case is a very different type of routine. They're both very routine-ish type kind of places, but you don't just do the same thing all day long, every single time, right? You bounce around is what I'm saying in anesthesia. So it's very different. Patient populations. I just kind of spoke to that a little bit. As an ICU nurse, like I said, I saw medically acutely sick patients. I worked in the medical ICU. If you work in the CV ICU, you see fresh open hearts or maybe fresh AAAs or, vascular patients of some kind. But, that's what you see. That's what you're used to. You don't see, a huge wide range of patient populations. You don't see a 2-day-old baby for a pyloric or a week-old baby for a pyloric stenosis and then go off and do an OB case and come back and do a general robotic case, all in one day, all different types of patients. And you also say something to be said too is as a CRNA, most patients who come back for surgery have been worked up, meaning they've had, a PAT, pre-admission testing and all those things, but you still get emergencies from the ICU or from the ER that come back emergently to the OR, like a trauma, okay, or someone who maybe has dead gut in the ICU who's really sick. So there are things that are necessarily not planned or expected, and the patients are not primed and ready to go. In fact, they're near death. And so you do also sometimes get that thrown into the mix too, where you could have a beautiful lineup and then they either delay or cancel your case, or maybe you're the CRNA whose case cancels. Now you have the open room and you're like, oh, and then you get the trauma coming up or, whatever's kind of coming from the ER. So again, pretty acutely, your shift can change. I've also had times as a CRNA where, I might have a really nice AV fistula room where it's like really nice and easy all day, some max, and they're like, Jenny, we need you, a ruptured AAA coming next door. We need to pull you from this room, put someone else here, and we need you over there. And I'm like, okay, let me brace for impact. Okay, I'm going to leave my nice cush room to take a train wreck. Okay, I got it. It'll be fun. It'll be good. So I've also had that happen too, where depending on if you're an open heart team or something like that, or if you're maybe the CRNA who does a lot of peds, you could be pulled from a room to go do a case that comes in that they want you for, right? Which is really kind of, I always was kind of like, I'm kind of honored. Great. Thank you for thinking of me. I'll come do it. So I never had a problem with that. I think it's to be expected and something that I think you should always strive to kind of be someone that they can go to take kind of the mess that comes. All right. So that's patient population. Scope of practice, this is probably, other than the work environment, the scope of practice is probably what's the most different. And I actually think what is the most enjoyable part about my job, other than the fact that I get to see a variety and I get to do a bunch of different things with different patient populations, the scope of practice by far is my favorite piece that is different from being an RN. Now, an RN, don't get me wrong, especially in the ICU, you get a lot of critical thinking. You get to like really kind of think, okay, this is happening. This is what's going on. This is what they're on. This is their disease process. You know, what can I come up with that they need. And you're doing that whole process as an ICU nurse, but you're also very heavily relying on what are my order sets, that I'm going to tell the doctor this, what is he going to say to me, maybe even anticipating what he's going to say to me, or, you're essentially kind of become used to kind of relying on someone else as like the head chain of command to kind of assess your thought process versus, and don't get me wrong, I'm not speaking for every nurse, please don't take it that way, because you could be just the opposite. But where I was 3 years into my ICU career is I very much so still was like, okay, this is what I think, and I'm thinking for myself, but I'm also confirming it. I'm having someone say yay or nay all the time to me, right? Whereas a CRNA, you are the one saying yay or nay. You are the one calling the shots. You are the one having the final say on what needs to be done, what's going on. And don't get me wrong, you still have a team to collaborate with if you have questions, but you may or may not need to do that. And you have the knowledge and the power to say, I either need to ask this question or no, I know the answer and I'm going to move forward. And then you own that. You own that decision. And it's really empowering and just incredibly rewarding. And this is where the whole autonomy piece comes into play with being a CRNA that you'll read on Google. So if a CRNA program asks you why you want to be a CRNA, don't just say autonomy. Explain what autonomy means to you and why and how you would use it as in your CRNA practice. Explain how you use it in the ICU too. Explain how you think through the disease process of your patient and the drips that they're on and the vital signs you're seeing and what it is they need. Have that piece of I'm critically thinking through what the patient needs from me, and I'm coming up with my decision to make this judgment call. And yes, I may still have to ask a doctor about it, but you're still asking because you've thought of it, right? So when you're in the operating room, again, you're making these judgment calls all the time and you're assessing all the time. And you're also assessing as to whether you need to say something to the surgeon, whether you need to say something to your attending or your OR staff. I mean, if I had a problem in the OR and I'm like, if I knew it was a big problem, I would call my reinforcements in a heartbeat. Get your butt in the room. I need you at the bedside. This is about to go down, right? I need all hands on deck. You always trust your gut instinct to know whether you need to escalate care. And you also have to be good at asking and delegating what other people in the room need to be doing for you and for the patient. So you get really good at being bossy, which is the fun part. No, just kidding. But, if you have to understand what the patient needs so you know what to delegate. So that's kind of where I feel like you start these skills in the ICU as an ICU nurse, and I'm sure in other areas of nursing you do as well. And again, I'm speaking from my ICU experience, but it kind of amplifies as you become a CRNA. Now, when you start off in CRNA school, trust me, you're going to be intimidated. You may be scared. That's okay. It's okay to not want to walk in the OR on your first day and to demand everyone's attention and bark out orders to everyone. And I don't expect you to, nor should you. But I encourage you to kind of find your way and find your voice and find your path and watch your current CRNA and what they do. Learn from them on how they speak up, on how they communicate, on what they ask for, what they don't ask for, what they delegate. Pay attention to those things because that's exactly what you're going to be doing when you're on your own. And so I think this process again starts while you're getting your bedside skills, is becoming comfortable delegating, being comfortable speaking up when the patient has a need and asking for things because you've had a thought process that led you down that path. So it all starts there. Now, when I say you don't necessarily need to escalate it or delegate it or ask a question, it's because you don't. If the blood pressure is dangerously low and you want to start a levo-fed drip because you know that that's what's going to be the best for the patient because a neo drip's just going to squeeze them and not give them any beta, and so they're potentially could make their whole put them in worse heart failure essentially if you're squeezing the pipes but not giving the pump some extra oomph. So start a levo-fed drip, draw it up, get it ready, hang it up, string it, go. I'm not saying don't notify the surgeon and the attending that you had to do it, but you do it. You don't wait for an order. You don't wait for a pharmacy to mix it up. You just get it ready. Same thing, like, okay, what if they get acutely hypertensive and all you have in the room was a bottle of nitro? Okay, we'll dilute it down to 20 mics per and give 20 mics. Get the pressure down, quickly and acutely, but it's not going to last. You don't have to ask for permission to do that. You, again, have education and skill set knowing how to safely use and titrate that drug. I'm trying to think of other ways. There's other times, too, where you do use your skill set to ask questions. Like maybe you're getting ready to extubate your patient, but you're like, something doesn't feel right about this. They seem a little weak. Maybe they're already a respiratory cripple, but you're like, I just don't think they're going to fly. So call in someone to the bedside, whether it's another CRNA, your attending, whoever's available, and say, hey, what do you think about this? This is why I'm questioning whether this patient's going to be okay extubated. And then they can kind of say, yeah, I agree with you. I'll be here. Let's go ahead and take the tube and see. And maybe, if we have to reintubate him, we will. Or maybe we won't extubate him at all. Maybe we'll just take him over tube to the ICU and let him recover more slowly. Whatever the decisions ends up being, you've now had a second opinion to your thought process, right? But again, when you are in a situation where you have to react and do something quickly, you are the one calling the shots and giving the drugs and asking for things. Another example would be when I had a patient extubated after they turned the bed 90 degrees. The surgeon got in there, extubated my patient. And so, here I am, trying to mask the patient and shove the vent so I can actually physically do it without having go-go gadget arms. Then they spasm, and really bad. Laryngospasm, turning and then desat the whole 9 yards. So I had to look at the PA, the physician assistant, and I had a vial of sucks and a syringe. I didn't have it drawn up. I had a vial and I had a labeled syringe. I go, grab that syringe that is labeled succinylcholine, draw up 1 cc and push it. And she did. And the patient broke the spasm. In the meantime, I also said, call the attending to the room. We need to reintubate the patient. I want another set of skilled hands there in case it went down and he didn't, I wasn't able to break the spasm or something, gosh forbid, worse were to happen, like he were to Brady down or code. So by the time I broke the spasm, attending was down in the room, then we could reintubate, boom, done, go on with a happy little case, right? No big deal. But I had to use my delegation to give orders because I had my hands full. I was all by myself trying to manage a spasm, giving positive pressure to hope that I could break the spasm. I decided that I'm not going to break the spasm. I have to give drugs quickly before he desats even further and potentially Brady's down and codes. And so I had delegated that task to the physician assistant who was right next to me at the time. And it ended up being, so that's kind of like another example, which I think it just always kind of helps to hear examples of, your thought process of what you do. But think about it. If you're at the bedside in the ICU and something's happening, you're going to delegate someone else to do something for you, especially if your hands are tied and you can't do it because you're doing something else. You're going to say, hey, I'm in here helping stabilize this patient, or hey, I got to, draw up some epi. Can you start chest compressions? Whatever the situation may be, you essentially start doing those things as a nurse. So that's kind of an example. But the scope of practice for a CRNA, you guys, again, you are it. You are taking care of that patient. You are in the room with them the whole time. Depending on the type of practice, you are either going to sleep with just you in the room as the sole anesthesia provider, or you're calling in, or you're going to have an attending at your bedside or another anesthesia provider at your bedside. To make sure everything goes smooth during induction. If I have 2 people in the room for induction, typically you're masking the patient down while the other person pushes drugs. I work at a peds hospital, so they typically don't come back with IVs. And so I'm masking the patient down and wrestling them, you know what I mean? And then once they're calm enough or under enough gas, then I have the attending start the IV, push the drugs, then I intubate. And then you go on. Now, waking up, same thing. Some places you're going to have the attending come to the bedside and they kind of just hang around in case you need them for anything. Other places, you're waking up routinely by yourself and you're only calling the attending to the bedside if you have a problem. Other places, that's just, again, you're only calling someone to the bedside if you have a problem. It just depends on the type of practice you work at. As far as how that goes. But you are otherwise in the room and you are doing the whole case by yourself. You're waking them up by yourself. You're taking the PACU by yourself. You're giving a report. You're going over to pre-op, doing your own assessment. Now, don't get me wrong. The attending will typically see the patient in pre-op and put in a pre-op assessment, but you're still responsible for doing your own pre-op assessment, to some extent, whether that's looking up the patient and the case previously, So you kind of know what you're walking into and then maybe if you don't have time, doing a quick airway assessment when they roll in the door, asking your pertinent questions and then going off to sleep versus walking over to the PACU after your last case and doing a full blown assessment. It just depends on where you work and what time you have. But ultimately at the end of the day, it's your responsibility to assess the next patient and do the whole case from start to finish. So that's the responsibility scope of practice. And again, you do A lines, central lines, IVs, epidurals, thoracic epidurals, labor epidurals, spinals, all kinds of fun hands-on stuff. Blood patches. Sometimes they're coming from the ER because they've had a spinal tap and now they have a bad headache, so you do a blood patch. Or maybe they had a wet tap with an epidural, so you do a blood patch. I mean, there's a variety of procedures that you can do as a CRNA. And as far as anesthetics go, I mean, there's inhalation induction, there's IV induction, there's awake intubations, there's various equipments to manipulate someone's airway, a fiber optic scope. When I would do my lungs, we would intubate with a double lumen tube. And then one of my responsibilities was to take the fiber optic scope after we intubated and confirm placement of the tube. And so I would be manipulating that scope down the tube and confirming placement. All kinds of stuff. A lot of fun hands-on things. If you like hands-on, if you like pharmacology, pathophysiology, you will like being a CRNA. All right, so that covers scope of practice and role. Again, this kind of goes into the fact that, again, you essentially have full responsibility from start to finish of the anesthetic. You have full responsibility. Your scope of practice is not inhibited. You don't have to answer. Like, you answer to yourself as far as if you make a decision, that's your decision. And so again, you take ownership of that and you don't really rely on someone else to kind of oversee that in a way, is what I'm trying to get at. But you also equally know when you need to ask questions, and asking questions is a safe way to practice. You should ask questions and confirm. I can't tell you sometimes I use like my Vargo app or some other app to look something up, right? Because I want to confirm what I think is the right dose. I always double check my doses. I always triple check my vials. What I do when I get out a vial, for example, is I know what vial I grab it out of the slot. I look at it, I look at the title, I draw it up, I look at the vial one more time, because there's that confirmation bias where you think you see the vial, you think you selected. And so you're always doing things in your practice to make sure what you're doing is safe. Because again, at the end of the day, you have a very big role, and potential for mistakes exist in big roles. It's funny. I recently compared the fact that, if you think about it, no one really just wants more responsibility in life, right? Like, okay, here, I'm gonna give you all this responsibility, have fun, right? And you're like, oh, but the reality is, you guys, the more responsibility you take on in life, usually the more reward that comes with it. Like I said, things that are rewarding are also usually hard. And that includes responsibility. So the reason why CRNAs have such high responsibility is also equally the fact that they have a lot of job satisfaction, a lot of career satisfaction that comes with it. It's not, walk in the park. It's not, every rainbows and sunshines. I mean, it's a big responsibility, but it's also incredibly rewarding and satisfying to be that person for your patient. So that's kind of the role that in scope of practice to kind of round that all up. And then we'll get into like the basic, like to finalize this whole episode, the pay, okay? Because I did a whole episode on what CRNAs make, so you guys can go check the episode out. But I think it was episode 69 that I did that. But yeah, pay is obviously there, where, CRNAs, not only do they have a lot of responsibility, they're also compensated because of that. And so I actually, how on Facebook, every now and then, I'm not crazy about Facebook. If you probably know that, if you know anything about like any of the history with my Facebook group that we used to have. Now it's just for CSPA students. But anyways, I don't really like Facebook, but every now and then Facebook will ping you and kind of have like the perfect thing for you to see, right? And you're like, how do they know that? It's creepy. But they pinged me on a post in a group that I hardly ever visit anymore, but it was what a starting RN salary is. So I was like, I'm kind of curious. So I went in there, and it ranged from $24 an hour all the way to $46 an hour for a new grad starting position for an RN. That's a pretty wide range, a $20 range. That being said, it depends on where you live. The highest range was California and like New York, Manhattan, okay? Because it costs like $2,000 a month for an 800 square foot apartment where I have an entire home for that much, you know what I mean, in Ohio. So again, cost of living goes into the salary rate. But that being said, $24 an hour is what some places are still starting out at. And when I started as a nurse, maybe it was 24, 26. It was still pretty low. I started back in 2009 at $22 an hour. And by the time I started my anesthesia training, I was at $24 an hour. And so, and I live in Ohio, not crazy cost of living or anything like that by any means. But I remember feeling like that was not enough, and a CRNA, you're looking at on average for a new grad to be right around $90 an hour, I would say, maybe closer to 100, again, depending on where you live. But $90 an hour is typically what most CRNAs are making, even as a new grad. And then you get closer to $100 an hour with more experience. Now, that being said, my first CRNA position was $86 an hour. That, I want to say by the time I left that original position, I was closer to $88 an hour. And then when I moved, took a regional position, I went to $90 an hour. And then it's funny because when I took my peds position, I took a little bit of a pay cut. I went back to like $88 an hour. But I was like, if I would have been W-2, I would have taken a pay cut by a couple bucks. But I actually decided to stay PRN. And so I actually made more like 110 as a PRN. They just bumped us, I think, to 120. So as a PRN, CRNA. So depending on whether you're W-2, PRN, et cetera, depends on your pay. I also just took a 1099 position for the first time. Yeah, I'm experiencing 1099 where I'll whoop, and it's $180 an hour. So again, it just depends, and that 1099 position is an hour away, so I drive an hour there, hour back. So the way gas prices are, you can subtract some from that hourly rate, but it's still well worth it. It's still 100% worth it to go do, and again, it's kind of a different experience. Yeah, so I guess, the pay, if you want to compare the pay, that's the comparison, is there's really no comparison. I mean, on average, CRNAs are making well over $100 more an hour than a W-2 nurse. If you're looking at, $26 an hour versus 100 or more like $60 an hour more. Well, I'm making $180. And it just depends on where you work. But if you're making $100 an hour versus $26 an hour, again, you're making anywhere from $50 to $60 more an hour, which is equivalent to about $100,000 more a year on average. Now, that fluctuates, like I said, depending on what your actual hourly rate is. Now, if you're travel nursing, obviously, I'm not going to get into this episode on what travel nurses make, because I know that's also up in the air and a huge debacle right now. So I can't speak to what travel nurses are making, what the average is anymore. I know for a while it was pretty high, but I also know that that's been coming down. So I don't know what the future holds for that. But that being said, again, CRNA is not all about the money. I know that sounds cliche and kind of like, okay, Jenny, but it really is more about the career itself. The pay is a perk. By picking a career that you're going to be satisfied in and enjoy, the pay is a huge perk. It's not everything. And nothing you do in life, I promise you, friend, nothing you do in life will ever be worth a lot of money if it makes you miserable. I can 100% guarantee and put money on that. Would you want to clean up poop all day if you made, $1,000 an hour? I mean, I would probably do it for $1,000 an hour, but I would hate it. I'm just being silly with you guys, but ultimately at the end of the day, there is a big financial reward for becoming a CRNA, but it's really about the job. It's about taking away someone's fear, anxiety, and pain, and having the skill set to save someone's life and to do all kinds of cool procedures and epidurals and spinals and airways and A-lines and central lines. It's a lot of fun. So I hope you guys enjoyed this episode today. As always, thank you for tuning in. Be sure to leave a review. I appreciate you so very much. And I will see you guys next week. All right, bye-bye. Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.